Once again, thank you very much for having me here. So we'll go ahead and continue with our part two of what we discussed last time. Today, I know last time we discussed a lot about treatment planning, diagnosis, and kind of putting together a plan for your patients. Today, I do have two cases that I want to share. So it's probably going to be a short presentation today, maybe 35 minutes. I'm going to go over a couple of my patients. So we can start with something very simple. So these two patients are, one of them is overdenture, and then the other one is for a fixed hybrid or a fixed complete denture in the mandibular arch. It's kind of from the starting point where the patients come in, what do you do to diagnose, and putting together a plan, the surgery, and finishing up the case. So I have a couple of cases. I'm going to go ahead and show you those. So this is my first patient or my first case. She came in because she had lost her dentures, and she wanted to, or she was inquiring about implants. In the past, she did have some information about implants, but she wasn't financially ready for it. But at this point of time, because she also lost a denture, she wanted to inquire more about some kind of a fixed prosthesis for her. So as soon as a patient like this comes to your office, the first thing that you want to see is, obviously, you want to gather all the records like we discussed last time, your radiographs, your preliminary impressions, your history taking, medical history, and all that kind of stuff, just like what we discussed. But once you are actually ready with your treatment, what you actually are looking at this patient is, one, if they are a denture wearer for a very long time, you will see that the ridges have atrophied, correct? So in this patient, as you can see, middle third of the face, you see those wrinkles, the facial form does not have enough support. So what that says is, basically this person might benefit from some kind of a lip support, correct? Now, lip support can be provided with fixed complete denture, which can provide some amount of lip support. But if the patient has very atrophied ridge and if the lip support is very compromised, especially when you look from the side, now this patient, obviously the lip support is not compromised a lot, but in some individuals, you see that there's a huge deficiency of that area where the lip is really not supported. Now, those cases, you know that you need a flange to support those. So in that situation, you have to tell the patient, in order for us to get good aesthetics, a fixed complete denture is not a good option for you. So that's the first and primary thing, which I see a lot, where patients go in and they get fixed prosthesis in the maxillary arch, but after the final treatment is completed, either they end up with a very bulky prosthesis that makes it very difficult for the patients to clean because they have to make it bulky to give that lip support. And that is, again, not a good treatment for these patients. So sometimes you have to tell them, even though they desire to have a fixed prosthesis, sometimes you have to let them know that a removable prosthesis, something with a flange, is going to give them better aesthetics and have better function. So this is, again, frontal view of smile and side profile. As you can see, the lip is really not supported in that area. It's not very extreme, but this is the case that I wanted to show. But then other cases, you will notice that even on the side profile, there's going to be a lot of deficiency of that lip support. So you definitely have to consider having an overdenture. If the patient really desires to do implants, you can present an option of an overdenture for these patients, but definitely be very cautious to do something fixed in these patients, because if you have to provide that lip support, you have to cantilever your prosthesis a lot, and that makes it really difficult for the patients to keep it clean. Two is the patients are going to have something called as like a inversion of that lip, where basically if they have deficiency in this area in the nasolabial angle, and if you are providing only lip support with a fixed prosthesis on, more like this superior border, the lip actually rolls back and it gets inverted. So that's a very common thing that you will see in patients who have or lacking lip support, and they have been restored with a fixed arch in the maxillary arch. But again, this is the maxillary arch. This is the mandibular arch. As you can see, edentulous, you can see some of these ridges, although they are nice and healthy, the attachment is very high. So again, that's another indication. When you see attachments like these, which are really onto the crest of the ridge, you want to ensure that you might want to consider some kind of a pre-prosthetic surgery. If these patients need a lot of alveoloplasty, you're pretty much entering into the floor of the mouth where you're not going to have enough keratinized tissue, so that can cause failure to your treatment. So most of these denture patients, in a way, physiologically, after they've lost their teeth, they've already undergone some bone resorption. So you really don't have to do a lot of bone reduction in these patients. Most of the time, the areas or the patients that actually require bone reduction is somebody who has existing teeth. But typically people who come in with existing dentures, they really don't need a lot of bone reduction. Sometimes you have to recontour the ridge, but it's usually very minimal. So this is again infraoral view. You always want to take a look at the tongue position. Patient has a retruded tongue, as you can see, that makes your denture fabrication, especially in the mandibular denture, a little bit more unstable. So these are some of the things that you discuss with the patient and then tell the patient, okay, we can obviously make you a new maxillary and mandibular denture, but because of these consequences where the floor of the mouth is not favorable, the tongue position is retruded, that can cause instability of your denture. So fixed prosthesis can be done in the mandible. So what you do is in this case, because the patient did not come in with an existing denture, you want to set up your teeth. As I mentioned to you in the previous presentation, if I don't know where the teeth belong, I don't want to go ahead and jump and place the implants. I need to have a tooth set up. So in a case like this, in this case, because the patient had lost her denture, I decided to go ahead and make her an interim denture. But you don't have to necessarily make an interim denture. If the patient came in with the existing denture that is either broken or the teeth are not great, they're worn down, the position of the teeth is not good, you can either do a wash impression of that, you can scan that and then get like a printed denture that has adequate lip support, good incisor ledge position. If not, you could do a regular traditional way where you can make a wash impression for that, do your jaw records, and then set your teeth. So you don't have to process the denture, but at least you could do a wax setup and then evaluate your phonetics, aesthetics, occlusal plane. So you need to have that established before we can go ahead and plan for implants, correct? If the patient comes without any dentures, if I'm able to, or if I'm proceeding to placing implants and then figuring out where I want to have my teeth, that's not the right way of doing it. You have to have it the other way, where restorations actually drive where the implant position is. Okay. So in this case, instead of making a tooth setup, we went ahead and gave her an interim denture. So this is an existing interim or fabricated interim denture. And this is a straight frontal view and profile view. As you can see in the profile view with the flange, you can see that the lip is supported. So imagine if I were to do a fixed prosthesis in the maxillary arch, obviously she's going to have a deficiency in that area, because you don't want to have your fixed prosthesis go all the way to the depth of the vestibule, correct? And in, like I mentioned before, in this patient, the lip support is still adequate. In some other patients, you are going to see that the lip support is very compromised. So a flange is something that will give them adequate lip support. And if you have to add a flange, you have to inform patients you cannot have, or you cannot do a fixed prosthesis in the maxillary arch. So in this patient, as you can see, established occlusal plane. We made sure that we had a good incisal edge position, display, and all that kind of stuff. And at this stage, because I wanted to provide flange for my patient, we gave her options of doing, she did want to have implants in the maxillary arch as well. She had a palatal Niels or palatal house classification 3, which makes the maxillary denture retention a little bit more compromised. And of course, it makes the patients gag. They are a little bit more uncomfortable. So in order for us to address all those issues, we recommended a 4-implant maxillary overdenture for her in the maxillary arch. And then in the mandibular arch, we recommended a fixed prosthesis. So this is not the same patient's implant planning. Unfortunately, I was not able to get the implant planning. I was looking through my documents. I somehow did not find it. But anyway, I just had another patient, so I just put in this slide so you kind of understand why we have a tooth setup. So now if you look at this, basically this is the denture setup, correct? And you put these markers, and then you know that this is where you want your teeth to be. So when you're actually planning implants, you don't want them to go more facial. You want them to be in the right position, kind of equidistant from each other, and making sure that they come out from the occlusal aspect as much as possible. In some cases, you have to also consider multi-units. In those cases, again, you need to check the depth of their implants. So if you look at this picture on the left side, as you can see, this is a CT scan that's actually obtained with an existing denture. And then with the markers, you go ahead and merge it. And this is an implant planning. We use 3Shape. We have a couple of different software, Blue Sky Bio, 3Shape, Exoplan, whatever it is, you can go ahead and use those. So what I'm seeing in this scan here is this is where I want my implant to be. Now, although the bone is up here, if I did not have a tooth setup, I would probably end up placing my implant very shallow. That would leave with very little acrylic. Like, you see what I'm saying? So we want to make sure that you have enough of this acrylic height, especially if you're doing an overdenture. You have to have a locator, right? The height of the locator and the height of the housing and acrylic or the pink part, and then the teeth. So you need to have adequate space in this area. Typically for an overdenture, you need about 10 to 11 millimeters. That includes the locator housing, the pink part of acrylic, and then the teeth. So that's the reason why you want to have your tooth set up. If you did not have the tooth set up, there is no way for me to figure out how deep I want to place the implant, because as you see in this area, we're actually entering the sinus, but also we need a little bit of plasty there. So if we don't have that plasty done, you're gonna have a very thin denture, and if you start trying to pick it up with locator housings, the denture is going to be even weaker and more prone to fracture. Correct. Um, so based on that, you go ahead and fabricate a guide. So as you see, this is an implant planning. This is the same thing here. So once you have the implant planning completed, again, this is not the same patient, but these guides are for the same patient that I showed you before. So once you have your implant planning, based on the implant planning for the mandibular arch, we decided to do a fixed complete denture. So in this case, we printed 3 guides. So this is a denture setup. This one was an interim denture, but you can also do a tooth setup without processing it. If the patient already had an existing denture and if they don't want to go through another set of denture, you could just go ahead and do a tooth setup, put your markers, do a CT scan with it, and pretty much do the same. So you're going to end up with a guide like this, which is called um, the initial guide, which helps you position these anchor pins, right? So this anchor pins help stabilize this initial guide. Once you put this guide, this is going to establish where your teeth are. Now you go ahead and remove this guide and put the second guide into the same anchor pin locations. This is a bone reduction guide. This is actually upside down, but if you flip it upside down, this is where you want the bone reduction to be. So that way you can plasty the bone, make sure it's even. And once that is all completed and recontoured, this is the third guide, which sits in the same locations where you had your anchor pins. And this has the openings for your implant, and you can go ahead and place your implant. So what I'm saying is, from starting to finish, when the patient comes in, you actually not only discussed treatment options with the patient, but you also evaluated it. You've diagnosed the conditions, you've given her some options, and you have planned the implant placement, and you go ahead going into the surgery. Now, when we go ahead and do the surgery, this is the first guide that fits in. When you place the first guide, if the patient have an existing denture, you can also use that existing denture. That way the occlusion is correct. Basically, this is a or a tissue bone guide, because you do not have any references. If you just put this tissue bone guide on the ridge, because of relief, there's going to be a little bit of movement that can also interfere with your accuracy for implant placement. So in this patient, because we already had processed the maxillary and mandibular denture, what you could do is you can do a bite registration as the patient closes down in centric with her existing denture, right? And then you save that bite registration or your occlusal record, and then you put this guide. That way it goes or locks into the same position, right? So once you do that, you ask the patient to bite down, and then you go ahead and drill these anchor pins and then secure the first guide. So this is where the first guide is secured, right? And then once you secure the first guide, you verified and you can also mark the pleasure points for the patient at this stage. If you decide to do that later on, if you decide to pick up the prosthesis, you want to make sure that the vertical height is maintained. So after you do this first guide, you can go ahead and mark the pleasure points for the patient on the tip of the nose and the chin, and cover it with the tape. That way, during the surgery, it's not wiped off. And once you do that, you can go ahead and remove your guide and make an incision. There's a mucoperiosteal incision that's made. And if you see here through the tissues, you see the tissues being punctured with those anchor pins. So you don't want to reflect your flap before you know where your anchor pins are going to be secured into bone. So once you have these done, you go ahead and remove the first guide, you make a mucoperiosteal incision. In this case, I decided to kind of have a releasing in the anterior. That way it's a little bit better access, but you don't have to really, you know, uh, have a releasing incision here based on your surgeon's accessibility. They might want to reflect a lot of the lingual tissue. Sometimes they want to prevent the floor of the mouth kind of from affecting. So again, it's your surgeon's choice based on the flap. But once you have the first guide in, this is where the anchor pins fit in. As you can see, these are the osteotomy sites. Now, the second guide that fits in is called the bone reduction guide. So if you see here, the bone reduction guide actually fits in this area. So we want to do a little bit of plasty here just to kind of even out the irregular ridge. And also most of the time, these patients, when they come in, they end up with a knife edge ridge on the maxilla. So when they have a knife edge ridge, you want to kind of flatten it out. That way you have more width for your implant fixture head. So once the plasty is completed, so as you can see on the top, this is where the bone is. Once it's plastered, it's all flattened out. And then you go ahead and place your third guide, which is an implant guide, which fits into the same anchor pin locations. And then you can go ahead and place your implant. So this is how the implants look from start to finish with the 3 guides in place. So it's very streamlined, as you see. I don't have the implant planning in this slides, but typically when you do an implant planning, you want to verify again and see, okay, did I perform my treatment based on how my implant planning was done? And that's a good learning experience. And most of the time, like I said, these guides are not 100% accurate, but at least they'll put you in the ballpark. That way you don't end up with a lot of complications that we discussed last time. So again, this is how the implants are positioned, and this is how they were planned. We also plan for multi-units in this area. So you go ahead and place the multi-units, and in this case, because the implants had adequate stability, we went ahead and picked up the prosthesis. This is the existing denture, the interim denture that was fabricated. So if you see the implant planning, and this is the implant placement guide to where your actually implants are located, it's very similar, correct? So that means you've already planned everything ahead of time before you went into the surgery. And then this is traditional way of picking it up. I mean, these days you can do a lot of digital ways of picking it up, but this is all these techniques work. Digital is only one other way of doing it, but the principles remain the same, correct? So this is basically the 5 implants that have been picked up. Once you pick it up, you go to the lab and finish and polish. You can put healing caps that way the tissue doesn't collapse, and your surgeon can help you suture the flap back. And then you go ahead and load or immediately load the prosthesis. And this is how we finished the case in the mandibular arch. Now for the maxillary arch, the plan was to do an overdenture, as I discussed earlier. Similar to the implant planning, you do an implant planning in the maxillary arch based on the space that you require. You go ahead and plan your implants. And in this case, we did have the 3 anchor pins, as you can see. And this is a denture duplicated, and this is exactly how it fits. And this is what I was talking about, doing an occlusal record. So what you can do is basically, because the denture patient already had an existing denture, you can do this occlusal record with the existing denture, and then you put the guide back in and have the patient bite down. While the patient bites down, you want to make sure all these areas are sitting in the same location as your existing denture, because that's one way of verifying to make sure the denture is actually seated properly. Otherwise, you might have a little bit of that movement of your guide when you seat it, and then that can affect your accuracy of your implant. So this is another way to verify. So once you go ahead and do that, you can secure the maxillary guide with these anchor pins. Obviously, we did not have to do any bone reduction in this case, but these are implants that are placed through the guide, the 4 maxillary implants for an overdenture in her case. So once the treatment is completed in the maxillary arch, we did not want to place healing abutments right away. So we went ahead and put cover screws. So I gave her the denture back, and she was wearing it for a while. And when a patient come back after like 3 months or so, you go ahead and do stage 2. So as you can see, the tissues have completely healed. I feel like the maxillary posterior implants could be a little bit more palatal. I feel like they're a little bit more facial or buccal. But more or less, this is exactly where we had planned in terms of antero-posterior distance and having adequate distance between the implants. So this is the mandibular arch that has healed after 3 months post-surgery. Again, like I said, all these implants, as you can see, they're coming in the right location where you want them to be. They're not too facial. They're not coming out of buccal surfaces. So this is how you want to plan and make sure that your treatment is actually completed in a similar fashion that you want it to be. That way you can avoid a lot of complication. And from here onwards, it's a very simple case, correct? So this is how the tissues look. All the multi-units are placed in the mandibular arch, maxilla. We already have the healing abutments. And this is the radiograph of the maxillary and mandibular implants. You remove the prosthesis in the mandibular arch, ensure that the tissues are healthy. And sometimes you might have to do a little bit of recontouring of the gingival tissues. And then in this patient, we placed a locator. We picked the locator height. Again, I don't want to discuss all that basic information, you know, how to pick up the locator heights and all that kind of stuff. Remove the healing abutments, place locators in the maxillary arch. And from here onwards, it's basically doing the similar jaw records, making sure that you have the same vertical maintained throughout the treatment. And then we went ahead and did a tooth setup, made sure that there was adequate balance. This 4-implant overdenture in the maxillary arch pretty much functions like a fixed, but you still want to ensure that there's adequate balance for the maxillary removable denture. So in the maxillary denture, because the patient was, again, she had a house palatal throat classification as class 3, we decided to provide her with a metal reinforced maxillary overdenture that is palateless. So as you can see, my implants are pretty much equidistant. So where we actually planned them, we went ahead and fabricated a metal framework that can reinforce the denture. You transfer, again, this is all analog ways. There's digital ways to do it, but you know, this is pretty much a very simple method, very simple, straightforward case that I wanted to show you. But again, teeth setup is completed. Similarly, we went ahead and had the lab mill a bar first. This is a bar. This is a high water. It does have a millimeter of hygiene space in the to have adequate space for the patient to keep it clean. And once that is completed, I set up the mandibular teeth. And then this is a bar that's been tried in, maxillary locators. And this is a completed case. So this is centric, the frontal view, right and left, as you can see. We were able to establish a good occlusal scheme for the patient. And this is the patient without the prosthesis. This is with the interim. And then this is the final, having adequate to display. We made some minor modifications in the final prosthesis. Again, this is without the lip support. So if you see the patient, we were able to provide her with some amount of lip support, although in this case, maybe a fixed restoration would have worked just fine. But just for discussion purposes, I'm saying if the patient does not have adequate lip support, you want to prescribe an overdenture for that patient. So this is the final outcome. This is obviously when she came in without the prosthesis. This is the interim prosthesis, or you can do a tooth setup and then completion. We made some modifications based on some of the things that she did not like in the interim prosthesis, and we were able to modify that. Again, this is the profile view. So that was my first case. So I'll go ahead and get into my second case. Again, this is a patient who came in with some broken teeth. He desired to have some kind of a fixed prosthesis in the maxillary arch, but based on the finances at that point of time, he decided to do something removable. So this is the frontal view of the patient. He did have some existing restorations that were failing, some of the teeth that were non-restorable in the maxillary and mandibular arch. And this is the side profile for this patient. So this patient obviously has more than enough lip support. So in this case, you can straight away consider doing a fixed restoration, correct? As I mentioned, most of the time when patients have teeth, they do have adequate lip support. They haven't lost that lip support. And these patients typically require a little bit of plasty in order for you to have a well-fitting, a fixed prosthesis in the maxillary arch. So if you see this patient again, as soon as they come in, we talked about this a lot last time about diagnosing and evaluating patients. In this case, as soon as the patient comes in, you know that these teeth are positioned too far out, one, and also the display is way more than what I would want the final restorations to be. So what that means is when I see a patient like this, when I ask him to smile, and this is not even his full smile, most of the time you'll realize when the patient are coming for their initial visits, they're kind of uncomfortable. You're basically seeing them for the first time. So their smile line is a little bit more guarded. So you always want to also take another picture during the course of treatment just to verify. Sometimes these patients, they're like, okay, go ahead and give me a big smile, and this is how they smile. and you basically treatment plan based on this smile. And later on, once you finish the treatment, now they're happy with you, and they're more comfortable. As soon as they smile, they show a lot more of their gingival tissue. So in these patients, you always want to kind of try to take pictures in between treatment as you see them, like 1 or 2 visits. That way you kind of reevaluate. Patients feel a little bit more confident, more comfortable, and they typically open up and smile a little bit better, or greater smile. That way you can see the tissue prosthetic junction if you were able to do a fixed prosthesis in these patients. Again, this is a close-up view. If I were to build these teeth back up, I do not want my incisal edge to be in this position. I would rather modify it and place it a little bit higher. That way it's more aesthetic, all right? This is the intraoral view. Again, as you can see, oral hygiene is not very great. There's a lot of existing restorations that are failing, multiple areas that are carious. Again, similarly, in the mandibular arch, a lot of non-restorable teeth. He did have some existing, crown and bridge work done, but some of these restorations are failing. So at this point of time, you always want to go ahead and give patients some, counseling as far as oral hygiene instructions. Even if they are having all the teeth extracted, sometimes these patients think that once the teeth are extracted, I don't have to brush them. I don't have to maintain them. Again, that as a clinician, you are responsible for some kind of a maintenance care for these patients. So counseling these patients, making sure that they understand, okay, implants are one way to replace missing teeth, but they do need maintenance as far as keeping it clean, and things like those are important as well. This is a side profile of the right and left side. This is the maxillary view, and a mandibular view of the existing teeth. I mean, a lot of these teeth are non-restorable. But again, as I mentioned before, as prosthodontic or as any clinician, we don't want to jump into edentulating the patient. If at all we can save some teeth, that's great. We'd like to save those teeth. So these are the radiographs of the patient. Again, you can see a lot of carious teeth, multiple teeth that are pretty much carious to a point where we cannot really restore them. So in this patient, phase one was to kind of, he decided to have all the teeth in the maxillary arch extracted. In the mandible, we recommended, because of finances, he couldn't afford a fixed prosthesis. But in the future, that's something that he would like to get done. But for now, he was more interested in an implant-supported denture. So in the maxillary arch, there were a lot of teeth that once the existing crowns were removed, the tooth structure that was underneath it was not adequate to support any kind of a removable partial. So we decided to extract the maxillary teeth in the mandible. We decided to save some of these existing teeth and use it for a mandibular partial denture. So what we did is, as part of the initial treatment, again, in these patients, you can, if you are able to do a teeth try-in, in these patients, you can directly go to a surgery. Obviously, it's always nicer for patients not to go through multiple surgeries, but you want to make sure that you establish your teeth position before you go into the surgeries. And I know I discussed this in depth last time. In some patients, because the teeth are too proclined, you have to make too many modifications. In those cases, you cannot go to the surgery right away. So you have to do a teeth setup. In a patient like like this patient who presented, I did not have to modify the incisal edge too much. That means I just had to raise it probably like a couple of millimeters. So you can guesstimate and then directly go into the implant phase if you were to do that. So you really don't have to do a try-in for these patients or a mock-up in these patients. So in his case, we were able to save some of his mandibular teeth in the maxilla. We extracted all the teeth, gave him an immediate denture. This is again, he has a lot of facial hair, so you can't really see the incisal edge position, but we did modify it a little bit. And once that is completed, this is phase one that was done, where all the maxillary teeth were extracted in the mandible. We went ahead and tried to save a few teeth. I really wanted to save tooth number, I don't know what system you guys use, but a lower right side molar, we call it tooth number 30, but lower right side molar for a partial. It's always nice to have a molar here rather than having a distal extension going far back. But unfortunately, the caries had gone too far subgingival. We had to extract that one. But anyway, this is how he had healed after extractions. And then this is 2 months post-extraction. In the meantime, patient was wearing an interim or an immediate denture in the maxillary arch, and interim or an immediate acrylic partial in the mandibular arch. So once things have healed, I don't like to prep teeth right away because the longer the patient is in provisional, the more chances for the teeth to get caries and things like those. So I went ahead and during that phase, while the patient was wearing an interim partial, he was complaining of discomfort on the lower left side where he had a lingual tori. So I decided to go ahead and remove that tori. So that's the tori that was bothering him constantly. And in this patient, again, you don't want to prep the teeth ahead of time because once you reflect a flap, you're going to start having some gingival recession. So what I did is I went ahead and did the surgery first. We removed the tori, kind of smoothened it, and then closed it up. And as you can see, I did end up getting some recession. So if I were to do a crown preparation and if I delivered a crown or prepared a crown, my margin would have been a lot higher. And then after the surgery, typically they do have, or you want to anticipate some amount of gingival recession. So this is actually the implant planning as I showed you before. So now the patient, once he has the maxillary denture where the teeth were at the right position, correct? So this is where I want my final restorations to be. So I'm happy with the incisal edge. I'm happy with the lip support. I'm happy with the occlusal plane for the patient. What we do is we go ahead and do something called as a dual scan. Now with the dual scan, what we do is we place some gutta percha or some kind of a radiopaque markers on the denture. You have the patient do two scans. One scan is when he's going to wear the denture and then get a scan with the denture in place. Now you also want to make sure that the denture fits the intaglio of these, or the intaglio of the denture fits against the tissues very intimately. Sometimes if you're using an immediate denture, because the tissues kind of shrink over a period of time, you always want to do a wash impression, either with, you can do PVS wash impression before you place these markers, because if your denture is not stable, the guide that is being printed later on is not going to be stable either. So the most important thing is to make sure there is intimate tissue adaptation of the existing prosthesis. And if you're doing an immediate denture, because the tissues shrink after the immediate denture has been delivered, you want to go ahead and do a new wash impression before the patient's obtaining a CT scan. So these are the markers that you see, and this is three-shape implant planning. So you can see where my tooth or the occlusal surface of the teeth are, or the incisal edge of the teeth, and you go ahead and plan the implants. So in the maxillary arch, 4 implants were planned, and we want to make sure that they're not coming out from the facial aspect or the incisal edge, but we kind of angulated in a way. And sometimes you don't have a choice, the bone has to, or the bone typically indicates us to place an implant at an angle, but at least if you have a plan, if I were to angulate an implant, you can compensate it by doing some kind of, maybe if you're doing an overdenture with very severe angulations, you could use maybe an RTX locator, or you can use like a bar on top of the implants if they're too angulated. So that kind of gives me an indication. So it's not necessarily like all the time the implants need to come out from the lingual or the palatal aspect. In some cases, the bone will not let you place an implant in this perfect location. So if the bone will let you place an implant in a location where it's coming out more facial, then either you can move the implant location to another site, or you can consider doing an RTX locator that can compensate for more angle correction. Or if the angles are too severe, then you can consider doing a bar and then do locators on top of the bar. So this is the implant planning that was done. The patient did not want to go through like a sinus lift procedure, so we decided to go ahead and place these implants a little bit more anterior than the sinus walls there. Again, this is the anchor pins. This is the implant planning occlusal view. As you can see, equidistance, just like what we did for our previous patient. These are the anchor pins that fit in. And this is how the surgical guide looks. It's basically a replication or a replica of your denture. But this is what I was talking about. If you feel like the tissue is not adapted properly uh, in your immediate or an immediate or an interim denture, you want to reline it before you obtain a scan, because if the tissue is not adapted properly to the underlying or the integrity of the denture, then your guide is not going to be accurate. So all the planning that you did, you might have some inaccuracies. So again, this is the 3 anchor pins. And then once you, similar to what we discussed, again, it's the same step. It's the same recipe. Once you follow the steps, it's the same thing for every patient. We went ahead and placed these anchor pins. This is an overdenture guide, and place those implants in the 4 sites that we had initially planned. And again, in an overdenture, if possible, we like not to place healing abutments, but there is no rationale not to place healing abutments. I typically like to prevent any kind of disturbance in the healing. So I like to place cover screws and then close it up and have the patient come back at a later stage for a stage 2. But even with healing abutments sticking out, sometimes with the denture, patients are really not very careful. They are basically causing some kind of micro movement that can interfere with the healing. Also, at the same time, there were some bony protuberances on or bony exostosis on the distal aspect of the tuberosity. When the patient was opening his mouth, the coronoid process would kind of rub in those areas. So I went ahead and, because I was giving him an overdenture, I kind of recontoured the tissues, hard tissues in that area, and provided a little bit more space for my flange, because in the interim denture, my flange was very thin in that area. Went ahead and closed the surgical site. Again, this is after the implant placement with cover screws. A panoramic radiograph was taken. Again, something similar. Patient comes back, stage 2 done. We go ahead and place the locator based on the tissue height. And this is the second set of dentures that we're making for him. Now, again, you pretty much go through the same process of a conventional denture. You go ahead and do your initial impressions, final impressions, jaw records, your teeth setup. So this is a teeth try-in for that. In the mandibular arch, we decided to do a partial by retaining some of his teeth. So I was able to prep these teeth for a survey crown. And we were able to do occlusal record. Again, I'd like to have a teeth setup before we send an impression to the lab, because if I don't have a tooth setup, the lab really doesn't know how bulky they want to make these crowns. So sometimes they might end up making them too bulky, and then it would not look good. If you give them a tooth setup, at least the lab can see the contours. Okay, if there is a lateral incisor here and the premolar in this area, they know how to kind of bulk up the porcelain in that area to kind of make sure that it's even all across. So I'd like to give him a tooth setup. So this is basically what came back from the lab. Went ahead and I set the maxillary teeth, I set the mandibular teeth, and I sent the lab. The lab went ahead and fabricated porcelain fused to metal crowns. So this is the right and left side, right? And then this is crowns that were cemented, the survey crowns, based on the design, and then made a final impression at that point of time. Ordered a metal framework, made sure the metal framework was well fitting. In this case, obviously there was edentulous site on one area. Decided to do an altered cast impression for the patient. So this is a metal cast framework with border molding done on the lower right side where there was an edentulous space or a span. Went ahead and poured the impression, and again, altered cast impression. I know you guys know all these steps, so I'm really not going to go over it, but you do a final teeth try-in. And at this stage, the patient has already, or he already has the survey crowns delivered. This is the final teeth try-in that is being done for the maxillary overdenture and mandibular partial denture. Again, similar to my previous patient, because we had the 4 implants located, we decided not to cover the palate. This is similar to what we did in the previous patient. I went ahead and fabricated a metal framework and processed the maxillary overdenture with the 4 implants and then mandibular partial. And this is where we finished the case. This is what it looks like in the frontal view. Centric and lateral excursive movement, and this is a tooth display. Again, with patients aging, they always don't show the maxillary anteriors. They end up, as they age, they end up showing the mandibular teeth more. But the most important indication is when they smile, you want to make sure you have a nice even occlusal plane. So compared to where we started off with, the patient came in with teeth that were a little bit more protruded. The incisal edge position seemed a little bit longer. But as you can see, the smile, I mean, in the beginning, when the patient smiles, you barely see the gingival areas. But as I told you before, towards the end of the treatment, or as you're progressing into the treatment, once the patient get more comfortable with you, they usually smile a lot more. So this is really critical. So I would definitely encourage you to also take pictures in between or during the treatment. That way you can have a better idea. So as you can see the difference, when I asked him to smile the first time when he came in, look at where his smile is compared to when we finished the treatment. So if I were to use this smile as a reference, and if I were to do a fixed prosthesis in the maxillary arch, and finally when I finish the treatment, if he smiled this way, I would be exposing that tissue prosthetic junction. But anyway, so I hope that was good information. I mean, I just wanted to keep some simple cases, and I know we discussed a lot of diagnosis, treatment planning, but these are basically cases that are actually patients that came to me, and I started the case from diagnosing, evaluating, treatment planning, implant planning, and then finally treatment completion. So think patients like these, if you have a systematic way of handling these cases from the beginning, typically the complications are kind of rare. You can have a smooth, predictable outcome for these patients. With that, I will finish up. Thank you very much. And if you have any questions, we can answer or we can take those now.
Thank you, sir. Any questions? So one question here.
Yeah.
Hi, sir. Hi, sir.
Yes.
Sir, in the first case, you have shown that when you prepared the guide, you have verified your centric with the
Mhm.
interim denture. But in the second
Right.
case, when you stabilize your maxillary guide, how did you verify
Mhm.
your centric?
So basically, again, in the beginning, as I showed you, the patient, we gave him an infram or an acrylic partial in the mandibular arch, right? So that actually established the right centric for me. So
Yes.
what I was able to do is I was able to deliver an immediate denture in the maxillary arch and then an immediate interim partial or acrylic partial, like, it's called a stay plate or acrylic partial, whatever you can call it. We went ahead and delivered that in the mandibular arch. That way the denture is more stable. If I had him bite only on the 3 teeth, it won't be very stable. So that's one way to kind of identify and make sure that it seats in the right place.
I know, sir. In the second case, how did you stabilize your vertical dimension? In the second
So,
case, first case you have
right.
verified that with the
Mhm.
interim denture that you have given. But the second case, have you
The
made a
second case,
interim? Yes.
right. So second case, like I said, once the teeth were extracted in the mandibular arch, we gave the patient an interim partial denture. So that was supported with existing teeth and an immediate denture in the maxilla at the right vertical height, right?
Okay.
So you
Okay.
have a maxillary denture, immediate maxillary denture, and an interim partial denture in the mandibular arch. So that
Okay.
verifies my vertical height.
Yes. Okay.
Based on that, I went ahead and fabricated a guide. When the guide was fabricated, what I did is I went ahead and did a bite registration or an occlusal record with the existing immediate maxillary denture. And in the
Yes.
mandibular arch, he had some
Partial.
teeth and then a partial, yes, an acrylic partial.
Okay.
So I used that as a reference and made sure that vertical height is maintained.
Okay. Thank you, sir.
So one question for your locators. How do you take your impression? Do you use the locator impression copings or you go with the open tray?
You know, I've been, I don't know, for us, I always like to pick up chair side, especially if there are four locators with the impression materials. There's like distortion and acrylic, yeah, and cast and all that kind of. So I haven't had much luck with having four locators that fit perfectly. So I always like to just make an impression with impression coping. Typically, what I do is once the locators are placed, rather than just making an impression with those locators, I put the housing on there and then do my final impression. The reason is what I've noticed is if you don't have the housing on there, especially if you're doing a metal framework, you don't know how much space you need of acrylic around the metal housing. You understand what I'm trying to say? So I really
Yes.
don't, I don't really process with the housings, but when I make an impression and when I pour the impression, I actually have the housing. That way I know exactly how much of metal framework that I can build around that and have enough acrylic around it also. That also makes it a lot more easier when I pick it up later on. That way I don't have to drill it out too much. I already have the exact space for my locator housing. I just open it up a little bit more and then I can easily pick it up. It makes it a lot more easier. Some of my colleagues have, again, based on preference, there's no right or wrong way. You could go ahead and make an impression with impression copings and have the lab process your overdenture housings and deliver it that way too. But I typically like to pick it up chair side with either acrylic or GC pattern.
Okay. Okay, sir. Thank you. Uh, any doubts? Anything from the PGs? So we'll move to the presentation from our side.
Yes. Can I stop sharing my screen here?
Yes, sir. Start the PPT.
Was that? That's good?
Yes. Can you see your screen?
Yes, absolutely.
So this is a part of our endeavor so that we can also share some cases. I mean, this has two purposes. One is see, I mean, show our cases, as well as it gives an opportunity for our residents in oral surgery to see what is going on in the prosthetic side after the implants are placed. Because most often they see the surgical part and they don't see the completion of case unless it is pops up in social media, I guess. Okay?
For
So
sure.
this will give an opportunity, and I see that in future, let's see our residents also comes up and present their cases. So
That's great.
yes,
Yes,
sir.
I'd like to see this.
So, sir, we have two cases. It'll be. I'll just go through it. Madam, the connection. 1 second, sir. 1 second. Yeah, yeah. Okay, it's moving. Yes. That. Yeah. So this is the first case. He was a 68-year-old. He came from UK, specially for treatment here, based on a reference he had got from here. So
Okay.
this was his extra oral presentation. So this is how his clinical situation was. He had multiple teeth, which was mobile grade 1 to grade 3, and he had done a lot of periodontal therapy and done all sort of treatment. And he was like, he was, in his own words, he was done with it. He wanted to have a
Right.
fixed replacement, and finance was not a problem with him. He came in with the idea of fixed. He already had multiple consultation for implants. So we took an OPG. I mean, the OPG picture revealed even worse the situation of the bone levels and how the periodontal health is. So based on our OPG examinations, we took further little study models. We articulated them in the correct position. These are the diagnostic models. And this is an articulated model. So we were planning for an immediate implant placement followed by immediate loading. So we needed a
Right.
denture at the same vertical. And because the patient had a full complement of teeth, we decided to have an articulated model. And from using this as reference, we knocked off each tooth in the stone model and replaced it with an acrylic. So we were able to keep the same vertical by doing so. Each teeth was replaced, each teeth was removed from the study model, and it was replaced by an acrylic one.
Right.
And we had no chance of a trial denture, so we had to go by what how the what was the vertical that we had. So that was a wax up for an immediate interim denture. We had a CBCT with planning for about 8 implants. We were planning for an 8 implants here in this case. The patient was a tobacco smoker, and we had advised him, if you don't stop, it is not going to be a good, there can be failure. So we went ahead with it. So Dr. Indrajot sir placed all the implants at oral surgery department. So this was first day. On first day of the maxillary implants were placed, 8 implants were placed, and pretty good placement because it was immediate extraction and immediate placement. And on
Right.
the same day itself, we attached the impression copings. We kind of splintered it with nylon suture. That was one of the techniques that we developed here and published with JPD. So this helps in very easy way of splinting it. So this was also on the same day by around 1 o'clock. By around 1:30, we kind of finished the impression. This was a maxillary impression, which was taken with the mandibular or tray, as you can see. And then we had the master model.
Right.
So the denture, which is processed by this time, we used the master model to have a lap side pickup. So this was done so that I didn't want to spend a lot of chair side time trimming off the temporary cylinders and trying to adjust and trying to kind of see where it is exiting, because earlier cases we spend a lot of time. So once we did like this, and we had a very good good acceptance from patient, and it was much easier for the clinician as well. So this was after the lap side pickup. For the first one, I'm saying the lap side, we did the pickup, we didn't insert it. On the second day, we did the mandibular impression. Oh, sorry, mandibular implants were placed. Again, immediate extraction followed by impressions. By that was because we didn't want any discrepancy with because we are doing a lab side pickup. I didn't want any discrepancy in my implant position. That's why we went ahead and kind of made sure that there is no discrepancy, and we splinted all the impression copings. So yes, we got the lower mandibular impressions, again open ray impressions. We had the master model. We did the same thing for the lab side pickup for the lower as well. On the left side, you can see light body over there. That is just to kind of identify exactly where the implants are exiting, so that I make a minimal reduction in the acrylic.
Right.
And this was the immediate pre and post OPGs of your patients. So those was 8 implants. So pre, and then we inserted that on the third or fourth day from we when we started, we had the interim fixed dentures in place, and it came out good. I mean, we didn't have much occlusal discrepancy, or we didn't have to had a lot do a lot of occlusal adjustment to get our occlusion in place, because probably the reason is the patient had a good set of vertical because of its full complement of teeth. Now, this was his pre-op condition, and this was his interim fixed maxillary mandibular acrylic prosthesis. So this is how he went back, and we were quite happy with the aesthetics, and he was also very, very happy with the way it has turned out. And then this is at 6 months follow-up. This is a 6 months follow-up. The patient said he can't come uh, for, I mean, at 3 or 4 months. So he came at 6 months, and we had a thorough look at it. And luckily, none of the acrylic had debonded. There was no fracture of the acrylic, and we were really happy with how the acrylic kind of held on to its positions. So in some of these cases can come back horribly with a lot of teeth going around, breaking, midline fractures. And even without any framework or any metallic backup, we were this was in position, partly because of the good occlusion we had.
Right.
This is at the 6 month follow up before we removed the acrylic, and we had this is the occlusal view of the maxillary and mandibular, no fractures, pretty good. And the OPG, I forgot to put the OPGs in place. A very good bone healing with very minimal uh, bone loss. So we went ahead with removing, after removal of the acrylic. He was here for only 1 month. The time was a little tight. We had digital impressions for the mandibular and maxilla on multi-unit digital impression copings. And then from there on, this is how it was looking. This is the mandibular one that you see on the right side. This is the final impression that is used to record the implant positions. Next, we verified the implants using a single screw test for the mandibular as well as the maxillaries. And we were quite happy with the implant position. Even with 8 implants, the OPG had showed very good fit of the the verification jigs. And then the JR was done, the wax trial was done, and this is the kind of final uh, CAD, ExoCAD file that shows the design of how we wanted. We wanted to have an FP1 if possible, but yes, it came out that we needed a little bit of ping to be added at the end. So this was the complete set of digital designing that was done. This was done from DenCare, and this was the final prosthesis. This was a complete arch zirconia prosthesis, and they've done a beautiful work, I should say, with a
Right.
minimal anteriorly, yes, there was a minimal layering. Otherwise, the entire posterior was fully monolithic. The whole segment was monolithic except for some layering in the anteriors. And there was a little bit of pink which was added in the anteriors. And this was kind of the first case in the place itself with a full monolithic. And we were doing this case, I mean, such a big case with Dencare also for the first time, and we received the case exactly on the day the patient was leaving, and those we had very little time at the end. And when we received, we saw that they had placed pink in the anteriors, only the canine to canine. And I was like little surprised why it is like that. Later on, I kind of understood that for them, it is, I mean, the lab's way of working is they usually have pings on the from for the anteriors unless you have been told that you need on the posteriors also. This we only realized, this is something that we learned from the process, but it was not looking bad. And anteriorly, this is like, even though we wanted FP1, I mean, I would say that we had FP1, FP2, and FP3 in this case, because they kind of had the pink only in the anteriors. But yes, the aesthetics were very good, and I would like to thank Dr. George also, our alumni, because this case got finished in the lab at 9 o'clock in the evening, and we received it the next day morning 10 o'clock here. There was a lot of people who helped, and because the patient was leaving on the other day. So this was a lot of people helped out in making sure that it reached here on time. And yes, that's how it was looking, and it came out well. There were few things we could have improved. uh, I didn't have much time for getting a little better contours on the gingival one. I mean, I'm not. The occlusion was kind of really perfect. I have a video of showing the guidance out here. So anterior guidance, we'll be having a yes. So that's the anterior guidance with no contact on the posteriors. One of the things that we want to improve over time is the visibility of the multi units that is over there. Now we have discussed with surgeons, and we kind of came to an understanding about really placing it a little more deeper, so that that metal of the multi unit is not seen. So this is on the immediate post op. I didn't get any time to take another kind of review after a few days for how the tissue is healing up. But yes, the patient has a good sense of humor. He goes for hunting, and he sent this after a few days. Says, "Doctor, how is this for cleaning?" So yeah, I had a word with him the other day. He's doing well. So this is from his own place. So yeah, so that went well. The patient had a very good. He's doing well. I had a message with him yesterday, and this is another small case that we did, kind of inspired from what our last webinar itself. I would like to say. So we had a patient who was having a lower denture, previous lower denture, wanted another implant denture. He didn't want a fully fixed implant prosthesis. He just wanted a semi-fixed. That's what we call, to kind of make patient understand. So yes, this was the case. The OPG, the upper also is kind of a terminal dentition. We tried to tell him, but he was not convinced. So yes, we used Gatapaka for our markers. We use this is his own denture. We kind of use the denture to take CBCTs, and you can see the the opaque markers on top near the occlusal region. And based on how it is, we kind of planned our implant position, duplicated the denture. Here you can see even the getter because this was duplicated by our resident Dr. Subin and his friends. And we had an idea that because in the CBCT also there was bone was not great in the canine, so we thought we'll go with an implant position of A, B, D, and E between the mental foramens, and we wanted the exit to be favorable also, and not go too labily. And from there, these are the pictures courtesy of the surgery team. Surgery was performed by Dr. Indrajot sir, and so they used it. Yes, they kind of handheld it. Yeah, something that we can learn from your own. This thing is some way to stabilize it better. Yes, we can. Someday we'll soon get there. So we used the position over there. He used his pilot drills through the holes that I kind of gave him, because we wanted the implant position right there, and he used the pilot drills to kind of kind of fix the implant positions. And yes, we kind of got a really good implant positions. Only one was a mini implant. The other ones was regular implants. And I remember I told him, sir, I want the implants to be like a cricket stump. It should be as straight as possible. And yes, he kind of delivered that. And yes, this is a position. Yes, we had to shift one implant a little mesial. That was the left mandibular premolar, because it was coming a little closer to the foramen in a clinical evaluation. So yes, we kind of got a pretty good one, and this just got finished last week. We'll kind of follow up the later steps as we develop. So that is two small cases from our side.
Thank you. That was great. That was really great. I think one thing I would say is, obviously, you spent a lot of time kind of understanding and having your teeth set up and everything correctly. That way, the surgeon was able to deliver what you wanted them to deliver. So, and I told you this is a team effort. As both of them working together. And it's always good to kind of take a look at these cases after the surgery is done and see what can be improved. Like sometimes I would look at my own surgery cases and see what went wrong, because nothing is perfect. We all know that we like things to be perfect, but at least if you try to be perfect, you can get closer to excellent work, kind of thing. It can never be perfect. And I think looking back at your case, you can kind of learn through your mistakes and see what you can improvise, what went wrong. And I think having that discussion and having or sharing those cases with the surgeon is also really important. And from the surgeon, they will let you know, okay, these are the difficulties we've had during the surgery. Okay, the guide wasn't stable. So as a prosthodontist, you're going to figure out, okay, if the guide was not stable, what can I do to help the surgeon stabilize the guide? That's one less thing they have to worry about, right? So I think discussing those cases will really help streamline things a lot better.
Yes, sir. I would like to give the mic to sir.
Good morning.
Anji,
Uh,
good morning.
how are you? Fine.
Good, thank you, sir.
Uh, so, the main basis for doing any kind of procedure is planning, as what we have understood from you in the first lecture. And planning actually makes your things more easier. So now, when he gave me the guide, I did the punch, and then I opened the areas, and then I saw that the mantle foramen was quite close to my implant. So I have to shift the position little bit ahead of the foramen, so that we should not able instead of giving a good denture, we should not give him a paresthesia or something like that.
Right,
So that was actually functionality which has to be maintained along with a good occlusion. So
absolutely.
the main purpose of the thing is that in the end, we all actually, whatever patients we all are doing, we want that our patient should have a successful and a healthy smile and a good occlusion.
Anji.
So that is only what we are working for the betterment.
Uh, that's
So
great. I think you guys are
yeah,
doing a great job.
yeah. Thank you so much.
I
And it
congratulate you as
is,
a team.
thank
It's
you, thank you so much. Thank you.
Yeah, as Dr. Inderjot was saying, sometimes the surgeon has to make that critical decision. We as prosthodontists, we want the implants to be in this particular location, but the surgeon has to decide, okay, does this or this, if I place the implant in this location, does it have adequate stability? One, am I closer to some of the anatomical structures that can compromise the health of the patient? Is there adequate bone in this area? Is there adequate keratinized tissue in this? So those are decisions that the surgeon is going to make. But like I said, it's a team effort, and we have to respect each other's decisions. And at the end of it, as I mentioned, the patient outcome or that treatment outcome is the most important thing. It has to be betterment. You don't want to make it worse than what the patient came in with, right? So that's great.
Exactly. Any PGs with any doubts? I think they are still shy of asking doubts.
Oh, please don't feel shy. I mean, yeah, feel free to ask any questions. I'm a resident too. I'm a perio resident now, so I'm just like one of you guys. I have to go through all the lit reviews, read all the articles like you guys do. So please ask me any questions.
Yeah, we have one doubt.
Okay,
She's Dr. Savneet. She's a resident in oral surgery.
nice to meet you.
Good morning, sir. So I wanted to ask you one thing. You have used the anchor pins to stabilize the guides. How many anchor pins should we use in maxilla and mandible? Is there a criteria or like anywhere we can use?
I don't think there's a criteria, to be honest with you. I like to have three if possible. Always a tripod is better. But in some cases, although the anchor pins are great, if the denture flange doesn't go all the way deep, and if your implants have to be deeper than that, your anchor pins don't really work. So sometimes they don't even work. You have to stabilize just with your hand. So ideally, I like to have three if possible, but two is should be adequate. And sometimes we cannot place it on the buccal aspect, so we have to use it on the palatal side. So whatever you can do to make your guide secure, because at the end of it, it's all about precision, correct? So if you're going to put in all this effort to do all the planning and print a guide, if it's not stable, it's really not worth going through all that work. As long as you keep it stable, even if you're holding it and if it's stable, that's great. If the anchor pins can hold it, even if it's one anchor pin holding it and keeping it stable, it's great.
Okay, sir.
Sometimes the bone in that area is not it's not very dense. So if you place the anchor pin, it kind of keeps wobbling a little bit. So you always want to have two, at least a minimum of two, I would say.
Okay, sir. And sir, you are mostly using mucosa supported guides?
Mm-hmm. We do
Okay.
have, bone supported guides too. I did not include them in this presentation, but obviously bone supported guides are much more stable. But these were simple guides that can be printed, in office. So this is a simple version of it. But yes, I was talking to Dr. Kurian this right before we started the presentation that I looked at some chrome cobalt milled guides, bone supported guides where you can do bone segmentation and make it more. So yeah, you can take it to a different level altogether. But yes, bone supported guides or tooth bone guides are obviously much more stable than mucosa supported. There's going to be a little bit of a discrepancy.
Thank you, sir.
No problem. Thank you.
She's doing a meta-analysis. Actually, we are doing a meta-analysis on mucosal support or versus bone supported, surgical guides. So
Yeah,
it's
I
to
mean, you
get.
will see in the literature too, there's some kind of a variation. There is discrepancy regardless, whatever guide you use. They've always overlaid the implant planning versus where the implant position is. There's always going to be some variation, but at least as long as you're in that ballpark or that area, you can typically try to manage it. Main thing is to avoid a lot of complications. That usually happens not with a couple of millimeters here and there. It usually happens when the implant angles are off by several millimeters. So yeah, any kind of guide, if you can avoid that, the distortion, that'd be great.
So one more doubt. For the second case, did you do bone reduction? Did you have a
Uh,
bone reduction guide?
no, not for the second case. It's an overdenture case, so I did not have to really do. It was not very critical for that
Okay.
patient.
And even sir, when you are using a flap, I mean, when you raise the full length flap, so how do you manage the flap with the last surgical guide also in place? I mean, so that
Right.
it doesn't come in, it's in position without,
Yeah, that's another thing with anchor pins. You want to try and keep it as low as possible if you're not going to be doing any kind of osteotomy or bone reduction. That way you don't have to reflect the flap a lot, right? If you put your anchor pins almost onto the depth of the vestibule, that means the surgeon has to really reflect it a lot to kind of hold it in place. So those are some things that you want to consider. Again, once the flap is reflected, once the guide is in place, because you already had made those osteotomy drills for your anchor pins, it usually is very secure.
Okay, sir. Thank you. Anyone else with any doubts? Thank you, sir. That was
Thank you
such a
for sharing
nice
your cases
presentation.
too. Yeah, thank you for sharing. I mean, that was great that you maintained the vertical height. Obviously, the patient had existing teeth. We know that in the Torrell's article, there's a lot of ways to kind of determine vertical height. Pre-extraction records is one of them. So that's great that you maintain that, use that for your benefit.
Yes, sir. And I was telling Dr. Indrajot sir also, like, we can actually encourage our residents also to present few cases.
Please. Yeah, I would like to do that. I'm a resident too, just so that you guys know. I mean, so you guys can do it too. I'm a resident. I'm really just like one of you guys. I've done all these cases, documented all of these. So please
Yeah.
feel free to share them. We all learn from each other.
Okay, sir. Sure, sir. We'll work on it, sir. Thank you so much. Thank you.
Thank you again.
See you.
I will go ahead and share my email address. If somebody has any questions, they can directly
Sure,
contact me.
sure, sir. Sure. We'll do that.
Appreciate it. All right.
Bye.
Take care.